Okay, so I'll get started. I'm pretty sure I know everybody by now, but I'm Gina. For my senior lecture, I decided to talk about uncertainty in the ER. Basically, we know it's an inherent part of medicine, and it's something that ED physicians face a lot more frequently, and a lot of times with greater consequences than most other specialties. So it's just something that I've been thinking about a lot as I prepare to leave the safety blanket of being a resident working under another person's license, especially since this is something that we encounter on a pretty regular basis. So yeah, in medical school, we're taught that if we do a thorough history and a good physical exam, we usually have a good shot at coming up with a diagnosis. And then there's TV shows like House, where it's basically about a team that's made up of specialists called diagnosticians who run all these tests and get all this imaging right in time to come up with a zebra diagnosis and save the patient by the end of the episode. But when I'm actually in the ER, I end up seeing a lot of these vague complaints at least once a shift. So you're male with atypical chest pain, your 76-year-old female with dizziness, and the 62-year-old male with generalized weakness, no associated symptoms. And a lot of times, both after the initial interview and exam, as well as after all the testing comes back, I'm still not really sure what's going on with them or what to do with them. There's actually a study that estimated at least 37% of patients are discharged from the ED with a symptom-based diagnosis rather than a pathologic diagnosis. And so I think it's just something to think about anytime I encounter a medical or diagnostic uncertainty is how much testing am I going to do? When do I stop looking to find an answer? And then how do I dispose these patients? So uncertainty has always been a part of our reality. Medicine has changed a lot in the last couple of centuries in a way aimed towards decreasing it. So clinical radiography and EKGs became available around the end of the 19th century. Many other diagnostic testing and lab tests became part of our routine clinical practice in the last several decades. We've also made all these algorithms and pathways and have these apps on our phone that are fairly accessible that are aimed to decrease or aim to predict the likelihood that a patient has a certain diagnosis or an estimated prognosis of their disease pathway. But despite all this, the ER is still a large landscape of uncertainty, and it's one that we're dealing with on a daily basis. So throughout the lecture, I'm just gonna briefly go over the sources of uncertainty we encounter working in the ER, how it affects the physician well-being and stress, factors that influence our medical decision-making, and how we can manage dealing with the ambiguity. So I was just going to start off with just the sources we encounter. And it starts with the patient. So a lot of them come to the ER as unknowns. We don't know their past medical history. They might not even know their own past medical history. They come in with vague symptoms like dizziness, and they can't really describe the quality of it, when it started, what makes it better or worse. Or they might be altered or nonverbal, and they can't really tell you what's going on. And usually we can never find that EMS call sheet, and the contact phone number in the Epic chart is non-existent. So all of this kind of provides a limited information to the provider from the get-go. And then when you step out of the room, you still might have no idea what's going on. You can also encounter uncertainty with the diagnostics and treatment. So diagnostics testing isn't 100% specific or sensitive. And even if you know the diagnosis, you might not know completely the manifestations and causes of the disease. And then finally, there's uncertainty in regards to the benefit and harms of a treatment for an individual patient. So the literature surrounding treatments is constantly evolving, and recommendations are frequently changed as more information and clinical trials come to light. And then I think this is especially relevant for our patient population is we don't really know how their follow-up is. Do they have a PCP? Will they be able to see them in a timely manner, or will they have access to a specialist? So basically, there's a lot of unknowns in every aspect of emergency medicine. And on top of that, the ER has high volumes, high acuity, and high complexity of diseases, and that results in the need for rapid decision-making in a pretty ambiguous environment. There's always the fear that we're missing something big when we make decisions about patients, especially when the clinical picture isn't clear. And that can lead to high amounts of stress and feelings of vulnerability. So I feel like at this point, we've heard a lot about burnout and wellness. Burnout in the ER position especially has been a pretty popular discussion topic. There was a study done by Kuhn et al. That specifically looked at tolerance for uncertainty as a risk factor for burnout among ER attendings. So they sent out a questionnaire composed of 3 survey sections, including work-life satisfaction constructs, the physician's reaction to uncertainty scale, and the Maslach burnout inventory. And this survey was sent out to ED physicians who are members of ASAP and actively practicing emergency medicine. Most of them are trained in emergency medicine as a specialty and had practiced for more than 12 years. And most also practiced in hospitals with some sort of academic training program. They compared the responses for each questionnaire item for respondents who display a high level of career burnout and those who didn't. And they found that out of all the factors, concern for bad outcomes was the most strongly related to career burnout. As you can see, the other items that are listed under the discomfort with uncertainty categories, such as reluctance to disclose it, anxiety caused by uncertainty, those were not as strongly associated with burnout. And I think this makes sense because as ER physicians, for the most part, we're okay with a little bit of ambiguity. We chose this field because it's exciting. We don't really know what's going to come through the doors next. But when the unknown can lead to bad outcomes for patients, that's when burnout happens. I feel like I've left the hospital many times and thought about whether it was a mistake discharging the elderly patient with vague symptoms, but didn't really seem that sick. There's another similar study done by Takayasu et al. That looked at factors associated with burnout in EM residents. So they sent a similar kind of survey to residents from 8 EM training programs, and they found that intolerance of uncertainty was also significantly associated with burnout. So this is something that we're going to face every day, and it clearly has an impact on our well-being. We also respond to it in different ways. So if you had 4 physicians independently evaluate the same patient, where there was an area of uncertainty in their workup or treatment or dispo, the medical decision-making could vary significantly among each physician despite seeing the same patient. And that's because there's multiple factors that influence how we make decisions. So one of the big factors is our personality and an individual risk tolerance. There's a lot of psychological terms that describe a person's threshold for risk. One of them is ambiguity, tolerance, intolerance, and that describes the relationship that individuals have with ambiguous stimuli or events. They either view these stimuli either in a neutral and open way or as a threat. Other terms thrown out there are risk aversion and then anticipated regret, which is the fear of missing something. So it's the experience of regret we think we may feel in the future, typically about decisions we're currently making. And there have been a number of studies that look at physicians' risk tolerance and how they make medical decisions in the face of uncertainty. And a lot of them have found that physicians who are more risk tolerant, physicians who are more risk averse will order more testing and be more likely to admit a patient. There was a study done by Pine et al. That specifically looked at whether EM physician risk behavior scores were associated with the decision to use imaging in ER patients presenting with acute non-traumatic abdominal pain. And they found that the physicians in the least risk-averse quartile used significantly less CT and other diagnostic imaging compared to the other 3 more risk-averse quartiles. After adjusting for confounders, they found that there was a 15% difference in the rate of CT use and an 11% difference in the use of any imaging between the least risk-averse and the rest of the group. In a similar vein, there was a study done by Schreiger et al. That looked at the relationship between ED physician risk estimates and admission decisions in patients coming in with non-specific chest pain. So chest pain is a very common complaint that we see in the ER. And so there's a lot of risk scoring systems such as TIMI, GRACE, and HART. They obviously aren't sensitive enough to completely exclude ACS in the ED setting. A HART score of 0 to 3 can be associated with as high as a 1.7% chance risk of a bad outcome in 6 weeks. So overall, that's a fairly low percentage, but it may be above the admission threshold for some ED physicians. So this survey was sent to ED docs where they were presented with 5 case scenarios representing typical chest pain patients with negative troponin results. For each scenario, they were asked to estimate either the risk of ACS or a serious outcome on a qualitative scale of very low, low, moderate, high, and very high. After making the estimate, they then chose a disposition: admit to medicine, tele, admit to OBS, discharge home with a 72-hour stress test, or discharge home with a PCP follow-up. So on this chart on the right, each color corresponds to a risk rating. Dark green being very low, red being very high, and then all the other colors are for the in-between estimates. And so with each case scenario, even though all the providers read the same case, there is variability in their own risk estimates for that patient and whether they should be admitted or discharged. For example, in case 2, some providers rated it as a moderate risk, but they still would have discharged the patient, whereas others rated them as low risk but would have admitted them. So overall, it shows that it is rare for a patient to be discharged if they are deemed to be at anything more than a low risk. Only 7% of the patients who were deemed at moderate risk were discharged home. Another factor that influences how we make decisions is our perception of diagnostic testing. So there was a systematic review done by Hoffman that showed that clinicians more often overestimated rather than underestimated the benefits of testing, and vice versa when it came to looking at harms. So there could be a couple reasons for this. Some of it could be due to a cognitive bias called commission bias, and that results from the obligation towards beneficence. And basically it's the belief that harm to the patient can only be prevented by active intervention. So it indicates the tendency towards action rather than inaction. Another reason is that our skewed perception of testing is that adverse consequences from over-testing and hospitalizations generally occur in a much longer timeline than the consequences of a misdiagnosis. So a CAT scan might increase a patient's risk for cancer, but if it develops, it might not show for more than 20 plus years. In contrast, if we miss a consequential diagnosis, we're usually immediately informed of it through either formal or informal communications. I think we've all had that moment when someone comes up to you and says, hey, do you remember that patient you discharged? And you start feeling like a pit forming in your stomach. And then finally, our practice setting and culture significantly affect how we make decisions. As we all seen in the pod, ED crowding is very much a thing. For many clinical conditions, a period of observation is usually a safe and cost-effective diagnostic tool. But because of ED crowding and the pressure to make decisions quickly in the ER in order to minimize their length of stay, this approach is a little bit less feasible. So Kings County at least does have an ED odds unit, so it makes this approach a little bit easier. But outside, like in the community, there's a lot of places where you have to either make a decision of admit versus discharge in a fairly timely manner. In those instances, it's possible that when you're faced with this diagnostic uncertainty, it's just an easier decision to keep the patient and admit them to the hospital, with the reasoning that you're giving another physician a chance to evaluate and diagnose the patient, and you're also giving them time to declare themselves as sick or not sick. But then we do have to ask ourselves if we're doing them any service, keeping them in the hospital, if any testing will get us closer to the diagnostic truth, and does it really change their course. So another practice setting to factor in is that we often work long shifts. And when you start getting towards the end of a busy 8-hour and definitely a 12-hour shift, it's harder to really employ that critical thinking about what's really going on with this patient and whether ordering these tests and treatments will really benefit them. There's literature on decision fatigue that indicates when fatigue sets in, people tend to resort to more conservative behaviors. So one of the more well-publicized examples is actually parole fatigue. So prisoners with earlier parole hearings are more likely to be given parole than prisoners with afternoon hearings. And that's due to judges suffering from decision fatigue by the time afternoon comes by. This causes them to choose the default option that's typical in these hearings, which is to deny parole. In medicine, there have been studies that show there's more antibiotic prescribing during the course of the day. And so in the ED, this could translate to we end up doing more testing and imaging and more likely to admit these patients. I already mentioned earlier that there's uncertainty regarding the patient's follow-up, and that can also affect how we make our decisions. We don't know about their ability to follow up, or we think they're not going to be able to get it in a timely manner, or they just never go to the doctor. We might be more inclined to do a little bit more of a workup, be a little bit more conservative, and admit them to the hospital for further testing. For example, here we opt out of patients for ACS so that they can get an echo and a stress test. But a lot of times in the community hospital, that's not really a thing, especially if they have good cardiology follow-up and you know that they can be seen in the next couple of days. And then lastly, the litigation of the area might make a difference. Areas of the country that are more litigious might affect how you practice. So basically, practicing emergency medicine could be a large ball of stress and uncertainty, but it's something that we're all in for the long haul since we're all in residency still. So it's important to have the ability to be able to manage this in an efficient and healthy manner. So the most obvious step to managing this is to look for further information to reduce the amount of uncertainty that you have. And that includes doing the medical workup, setting up blood work, getting the imaging that you think is necessary, reading up on the medical literature and EVM and FOMED, calling a friend, so consulting with other ER docs in the area or calling a consultant for REX. Ultimately, though, you're going to have to realize that this strategy is going to be a little bit limited. From a practical standpoint, the effort of information seeking it takes time. So both the provider and the patient will have to endure a period of waiting, either for the patient's course of illness to unfold, for the diagnostic workup to be completed, for the effects of the treatment to take effect. And that can be difficult to balance with the whole ED crowding and workflow situation. And then from a theoretical standpoint, no amount of empirical evidence can can necessarily definitively answer what diagnosis the patient may have or what the right treatment is for an individual patient. In the end, human beings are very variable, so you're going to come across cases that don't fit all the checkboxes for a specific diagnosis and disease pathway. So other strategies to manage uncertainty is to change our mindset a bit. We need to recognize that attaining an absolute certainty isn't the goal, and it's basically impossible in medicine. So rather, we should try to be skillful and efficient, and then try to find that sweet spot between having clinical confidence and risk aversion. Obviously, that will take time and experience to really develop that kind of balance and gestalt. Additionally, part of changing the mindset is to promote a culture in the ER where ER decisions aren't criticized retrospectively according to information that becomes available after the initial visit. And then it's also important to realize that an ED return visit isn't necessarily the failure of diagnosis or treatment on the initial visit's end, and that it isn't saying that the decision-making for the initial visit was outside the standard of care. Sometimes the patient's disease pathway may have just evolved in ways that you wouldn't have been able to predict. So also if a patient bounces back, maybe they were able to seek help because they were given clear discharge instructions, which is a central tenet to our specialty. And then another important part of managing our own uncertainty is to manage the patient's uncertainty and to communicate well with them. So it can be very difficult to tell a patient that their test is completely normal while they continue to experience symptoms that are uncomfortable to them in the ER. We've all had patients come in saying they were seen at another hospital before this visit and they didn't do anything for them. And then later during their workup here, we either do the chart review or we call the hospital and we realize that they basically had the same testing and imaging done that we're doing currently. It was all normal. And I think a lot of times we tell patients everything is normal, but forget to acknowledge that they're still feeling like crap and are probably scared about what's happening to them. So it's important to validate the fact that they're still having these symptoms. We could tell them that while we don't know the exact cause, we have crossed off many of the life-threatening things, and that we'll continue to treat their symptoms and make sure they get appropriate follow-up. So it's not a perfect solution, but at least we can reassure them that they're not going to be dealing with everything on their own and grasping for straws after they leave the ER. And then there's also the patients where you basically know right after seeing them that you're not going to have a definitive answer for them. In these cases, it could benefit to manage that expectation up front by saying we might not be able to give them a definitive answer at the end of the visit, but we're going to go through with this plan, make sure that they're feeling better, and try to give them the appropriate follow-up that they need. So for low-risk patients especially, this empathetic care may reduce their anxiety more than any additional testing would. And then finally, if there's a case of substantial uncertainty with multiple options available and no clear-cut best option, there's always shared decision-making and presenting the options and discussing it with the patient. This is also a time to discuss limitations and more intensive testing and treatment. Based off of literature out there about it, quality medical decision-making is described as having these 5 components. It should be based on the best clinical evidence, incorporate the patient's values or preferences, involve them in the decision-making to the extent that they want to be. It should be endorsed by the patient, family, and physician, and feasible to implement. So shared decision-making will really allow you to assess their values and preferences so that together you can determine the approach most appropriate for them. And while the medical uncertainty might still be there, shared decision-making can help alleviate the stress both the provider and the patient may feel about it. So basically at the end, I just kind of wanted to see the faculty had any input in terms of how they approach medical uncertainty and like the factors that influence their decisions, because it's definitely a very nuanced subject and there's really no right or wrong way to approach it. Yeah.
Very good, Gina. That was a very tough topic. I think that as you go along in your career, you get a certain sixth sense about things. So I like the fact that you're saying that they have to take the entire patient into consideration. We could talk about, you know, this article says this and you could safely discharge this person. It doesn't always work with your patient population. So if somebody doesn't have follow-up, you know, or you're trying to arrange follow-up, that would you know, make you err on the side of being conservative, right? You could say, you know, that you admit everybody, but no, that's not the case. But you always have to do what's best for the patient. I think the last point about the shared decision making is excellent. And if the patient is comfortable with it and they have a close family member, I like to tell them both. So that's also very helpful to tell, because sometimes the patients, just like anybody, they go into a strange location and they didn't listen to it, they didn't hear half of the things you said, even though you give them printed instructions. It's still always nice if they're comfortable with it and they have, a close relative or a dear friend, then you could help. That also would help you in your shared decision making.
I feel like people develop different styles depending on their practice, and I think you guys notice a large diversity in terms of different attendings and how they deal with uncertainty. I agree with Dr. Lucchese. I think it depends on where you're practicing, your own experience. You kind of develop that spidey sense of the picture kind of implies. But again, it's a big issue in emergency medicine. It can be very debilitating at times to deal with the uncertainty and that feeling. I think following up on your patients can help. Some people are good at that, and some people are not. Sometimes that can be a defense mechanism too, not following up on the patients, just assuming that things went well. But you'll develop your own kind of style and your mechanism to deal with it. I don't know, any other faculty? I mean, we definitely all have a wide spectrum of how we deal with disorder. More tests, going with a gut.
I think a lot of times we think that there's a right or wrong answer, right? And sometimes faculty will be like, well, you have to do this, and that's the right way. And somebody else will say, you have to do this. I think it's really important to realize that most of the time, there's not one right answer and there's not one wrong answer. And obviously, there's always things that you could do or wrong, like something that's going to harm your patient or something you're going to miss a diagnosis, and those things are wrong. But sometimes the decision to, let's say, do tests or not do tests, there's not a right or wrong. There's not like an obvious yes or no, and it's important to realize that and be okay with that, and just choose one. And that's the hard part, right? When do you choose to do tests and work up, and when do you choose not to do tests and work up? There's not always going to be a simple yes or no, and you have to really be comfortable with uncertainty. No matter how many tests you do, even the most conservative attending who does CAT scans on everybody, they're going to miss stuff because you obviously can't get a CAT scan on every single patient who walks into the room. You can't get labs on every single patient who walks into the room. There's always going to be an uncertainty. And the important thing is to realize is that, and as you kind of point out, sometimes doing tests and can harm patients, right? And it can lead to all sorts of unnecessary things, and sometimes admissions, sometimes the easiest way to admit a patient, you think you're being more conservative, but really that leads to harm, right? Because, you can cause a lot of harm inside the hospital. And so it's important to realize that doing more does not necessarily mean you're doing the safest thing for the patient or for yourself. And it's really being able to embrace the uncertainty. And if you can't embrace the uncertainty, you're going to have a very difficult time as a whole. There's always going to be uncertainty. I have uncertainty all the time. I may not show it, but it's there, right? I can't know everything. We can't know everything. We don't have, no matter how much knowledge you have, no matter how much you know of the literature or the books, there's always going to be uncertainty. And sometimes you're going to be wrong. And I do think that following up can teach you a lot. You learn a lot about the mistakes or the near misses that you have. A lot of times it's just luck. Honestly, there's luck in this game like anything else. And you have to really embrace that uncertainty. And no matter what you choose, whether you go with the test or not go with the test, just realize it's okay to be a little uncertain, but in the end, you have to make that decision.
All right. Those are my references. Then obligatory thanks to the residency and PDs and everybody. And then shout out to my class as well, who are a bunch of wonderful and weird people. And I'm really happy I got to spend the last 4 years with you. And